Welcome to the new Ortho Info podcast, a monthly series where board-certified orthopedic surgeons provide in-depth answers to frequently asked questions about bone and joint conditions, treatments, injury prevention, and more.
Welcome to the Ortho Info podcast. I'm Dr. Matt Darren, orthopedic surgeon at the Cleveland Clinic and adult reconstruction section editor for Ortho Info. In each episode of the Ortho Info podcast, we answer a different question that we as orthopedic surgeons hear from our patients. In today's episode, we answer the question, what can I expect from a knee replacement surgery? Joining me to answer that question is my colleague, Dr. Nicholas Scarcella, adult reconstruction surgeon at the Cleveland Clinic and our director of fellowship education. Dr. Scarcella, thank you for joining us today on the podcast.
Happy to be here.
What is an adult reconstructive surgeon? Why did you choose this specialty?
Yeah, so orthopedics is a field where there's surgeons that deal with different parts of the body regarding muscles and bones. Adult reconstruction surgeon or a joint surgeon is a person who expertise lies in usually total hip and total knee replacements. So people with arthritis and various conditions that they treat. Sometimes they can do shoulders and stuff like that, but mainly focused to the knee and hip.
And why did you choose that?
Yeah, good question. So, I chose the field of orthopedics in general. It's a part of medicine where people get pretty instant gratification. They have a problem, they get a surgery done, and you can see them progress relatively quickly, unlike other things in medicine that take a long time to correct. Adult reconstructive surgery is one that's even a little bit more quicker. So it's people who either they were previously active in life, they played sports, they had different fitness activities, or they were able to walk in the park or go to the store, and they get debilitating conditions such as arthritis and other things, and then they come in to see you and you're able to do a surgery and relatively get them back to a lifestyle that was taken from them within a few months. And that was a very gratifying thing to be a part of, so that kind of drew me to it.
It's pretty much the exact reason for me too.
Yeah.
You get to operate on people and they get better.
Yeah, it's nice.
People like you in the end.
That's also a very good thing to have.
Adult reconstructive surgeons aren't the only ones who treat knee problems. So sports medicine surgeons, general orthopedic surgeons, and primary care sports medicine doctors will as well take care of knee pain. So it can be confusing for patients to know which kind of surgeon or specialist they should be seeing initially. If a patient has really intense knee pain, is having trouble moving around, should they come to an adult reconstruction orthopedic surgeon to find out what's going on with their symptoms, or should they start somewhere else, get a diagnosis, and then see one of us afterwards?
Yeah, that's a good question. Obviously, we're a very subspecialized group being adult reconstructive surgeons. Most of the time, people already have an identifiable problem that lead them to our office or clinic. They either see their primary care physician, an APP, or a non-op orthopedic provider that diagnoses them with a condition that leads them to a joint replacement or an adult reconstructive surgeon. Arthritis, avascular necrosis, revision kind of things that's wrong with total knees and hips. And then they see us for those conditions. So most of the time, they're already diagnosed with something that is in our field. And you're right, there's a lot of things that happen in people's knees that aren't solved by adult reconstruction. People who are young have athletic injuries such as meniscal tears, ligamentous injuries, osteochondral things in young people, and those aren't really treated by adult reconstructive surgeons. Those are more done by sports surgeons. So majority of the time, our patient population is a little bit older, 50 or above, but on special occasions, there can be younger patients that see us. But again, most of the time, people already have some sort of condition they know about, and they're coming to our office with it.
Yeah, and I think a lot of times it varies on our individual practices.
True.
Some people like to see more patients, and they'll diagnose people and follow them through the conservative treatment all the way through the surgeries. And then other people's practice is more focused just on those surgical patients. From in the most cursory overview, we are surgeons, so we perform the surgeries, but that doesn't mean that we can't treat people otherwise too.
Very true. And it's institution dependent a little bit, right?
Exactly.
If you're at a big referral center with a big network of people in your institution, a lot of times those people are funneled into the system to you. If you're someone who's in private practice and you don't have that system, sometimes you got to see a lot more people to get those kind of people into your clinic.
Definitely. So one of the goals of the podcast is just for patients to understand what different things are in regard to adult reconstruction. And one question is, what is a knee replacement?
Yeah, that's a good question. And so a knee replacement, some people who will come into my office and they'll think like, listen, I'm getting my knee removed up and here I'm getting this huge joint replacement, and We do those replacements, but for bigger surgeries that are not related to arthritis. They're for more complicated things. But a knee replacement, while it's still a major and a big surgery, it is how I describe it to my patients. It's about a centimeter of bone getting removed from each end of the bone, a little bit, about a centimeter underneath the patella, and then the actual knee replacement component is these metal components, usually made of either titanium or cobalt chrome alloy, depends. There's different ones that we use for different situations. But about a base plate or a metal component goes on the bottom bone, your tibia. On top, your top bone, your femur, goes another metal component, and then in between there is a manufactured plastic, we call it polyethylene, and that is what articulates with the knee. So your femur rolls on it, and then underneath your patella, whether, there's different schools of thought, most of the time you get a piece of plastic too. So that's, in essence, the components that are in a knee replacement, plus or minus some differences between companies.
And what makes someone a good candidate for a knee replacement?
Yeah, that's a good question. When is a knee replacement, so someone's coming down the road and let's say we say, hey, you're ready for a knee replacement. What makes someone a good candidate? One is it's someone that can tolerate the procedure. They got to be healthy enough. There's a lot of medical comorbidities out there that we got to make sure people are optimized because we don't want them to have a complication. Common ones, diabetes. They can predispose people to having wound complications or infections. So optimizing it, make sure their blood sugars are at good levels. People who have immunosuppressive medications that gotta get held because they can cause wound healing problems, and a lot of other things. And we just make sure, quitting smoking, things like that, that you're ready for the surgery. What other things get people a good candidate for surgery is someone who can tolerate a big surgery and can do the rehab at the end. What my line to people is, total knee replacement is not a pain-free surgery. People will come in and rightfully so, we live in a world of advertisements, and they'll say painless knee replacement surgery or in some other place in the state, and I tell them that's not true. Knee surgery, I wouldn't say is incredibly painful, but there's pain, especially the first 2 weeks. They're tough, and there's a lot of pushing through a rehab process. So a patient who is a good candidate is someone that needs to understand that there's a lot of physical grit and rehab that you have to do while being sore. We give you pain medications, we give you things like that to relax you. You need to be able to do that to have a successful outcome.
Yeah, and I always tell people, you're not going to like me for the first 2 months.
No, correct.
You're not going to like it for the first 2 months.
Agreed.
It takes about 2 months to get good.
Agreed.
The other thing that I always kind of think about is, I kind of think of it like new tires on an older car.
Yeah.
So we're giving them new tires.
Yep.
But everything around those tires is the original parts. So tendons, muscles, ligaments, nerves, that's all stuff that can and often does hurt after a knee replacement.
Mm-hmm.
We can't replace that stuff. So it's not like I'm giving you the knee you had when you're 19.
Correct.
You're getting a new knee, it's a good knee, but it's a different knee than you've always had.
Yeah.
And I think the worse people's knee is before, to me, a lot of times the better they feel afterwards, because it's like I can make that a whole lot better. But if people can have a lot of knee arthritis and be functioning very well, I usually tell them, keep your own parts as long as you can.
I 100% agree. There's when people come in, you diagnose it with what kind of arthritis. We use general words: mild arthritis, moderate, severe. And like I said, some people come in with severe arthritis and they have absolutely no pain, and they're doing everything they want to do in life. And I tell them there's absolutely nothing to do. Obviously, they can have deformities and things that can make you go quicker to surgery, but the goal of a knee replacement is to get you back to activity and get you some pain relief. So even if you have arthritis, it doesn't necessarily mean you're a candidate for a knee replacement if you're doing fine.
Yeah, definitely. I'll cover those x-rays up and I'll say, don't worry about that. You come back when it gives you some trouble.
100%.
Now, there's a lot of options when it comes to surgery. Is there any specific approach or anything that may be better than another one? Or?
With knees, generally most people do. We call it a medial peripatellar approach. It's an incision that goes over the front of your knee, and then how we get in the knee is just on the inside of the knee through the joint capsule. With the approach, there's different approaches where people call it subvastus, midvastus, minimally invasive, things like that. They've studied this for a long time, and most have agreed that all approaches do about the same in the end. So it's just how people either trained, what they believe in, but at the end of the day, the main approach is the midline medial peripatellar. That's kind of the nuances of a medical approach, but they all do the same.
Along the same lines, robotic surgery's gotten a lot more interest in the past 5 to 10 years. Mm-hmm. What are your thoughts on robotic surgery, and what do you tell people when they come in asking about it?
Yeah, good question. Specifically with my practice, I do a little bit of both. I still do manual, which is non-robotic, or robotic knee replacements. I think, in general, robotics has revolutionized our field a lot. What it has certainly done is made a surgery very reproducible and very accurate. Studies have been coming out on whether at 1 year do they benefit or not between non-robotic and robotic. The jury's not fully out on that. But at the end of the day, it's a tool in our hands that we can use to be more accurate, more precise. And when we make cuts and put a knee replacement, we know that the cuts we made and where the knee replacement's going to go is where it's going to go. And any tool like that, I feel, always makes any kind of surgery or anything you do in life a lot easier and a lot better for the person.
I agree. There's a lot of benefits to robotics. I think those haven't been fully worked out in the studies, especially the more recent ones.
Yeah.
But I think there's certain elements to robotics that can't be argued with
Yep.
precision and reproducibility. And those are, we talk about important things in joint replacement. We're kind of doing the same thing every single time.
100%.
And we want it to be the same thing every single time.
In every field in life, whether it's how they manufactured cars or anything, robotics has influenced how that does because it's a reproducible thing that's accurate, that can even speed up a process. And I would argue that robotics can even speed up a surgery because it can make it safer at the same time. And it's something that's what it's doing in our field.
That's what I've found in my own practice is I tend to recut a lot less than I used to.
100%.
I think I used to recut the tibia. Maybe it's just my personality. I would constantly be recutting the tibia because I wouldn't cut quite enough the first time. And with the robot, I hardly ever have to recut because I know what it's going to be when it's done.
Absolutely.
So patients may have decided to finally pull the trigger and have their knee replaced. They have severe arthritis. It's hurting them all the time. It's impacting their quality of life. They don't just show up one day and get their knee replacement. What kind of things have to happen first?
Yeah, good question. Usually, again, people are coming through. Majority of the time, they've gone through some kind of conservative treatment, whether it's been over-the-counter pain medication, physical therapy. Sometimes people brace, whether that's works or not. And then a lot of times they'll get injection therapy with steroids or hyaluronic or gel injections that can treat the pain and treat the inflammation. It doesn't make your knee or arthritis go away or treat it at all, but it gets rid of the symptoms for you. Usually at that point where they have failed all those things, they're in the office and they're there for a knee replacement. So what kind of things do they need to get done for a knee replacement surgery? Usually what happens is you obviously see us, we go over the surgery with you, and we go over what it's going to entail. After that, most people will see some kind of preoperative medicine visit, whether it's with an anesthesia team or a medicine doctor, and that's someone who's going to look at your conditions and make sure you're safe for surgery. They're going to look over your heart history, lung history, any kind of medical condition you have, and make sure that a surgery would not pose a risk to you doing that, and they'll get laboratory work and EKGs, evaluations like that. Most of the time you already have the x-ray because you're seeing your doctor. Sometimes we talked about robotic replacements. Sometimes they necessitate a CT or a CAT scan for somebody, so sometimes they have to get that for the robotic platform to be used in a surgery. Then sometimes we even send people to prehab with physical therapy. And the prehab is meant for two things. One, it's always good to keep general muscle tone and function up as high as it can be before surgery because you do get weak and atrophied after surgery. And also they will establish the expectation of what rehab is going to be like afterwards. Because again, we talked about your first 2 weeks are not a fun experience. It's a lot of getting through the soreness. You're on a very strict pain regimen. You're trying to move through a sore knee and you're not, again, very happy with the experience until about 2 months afterwards. But they set the expectation of this is what it's going to be like. This is the activities you're going to do. You're going to be using a walker or a cane this long. And they set up the expectation so when the surgery happens, it's not some mystery afterwards.
Yeah, how about at home? Do they need anybody at home to help them out?
Yeah, that's a good question. Back in the day, I'd say about 5-10 years ago, we used to send a lot of people to nursing facilities afterwards with how healthcare is and Medicare is with how they change the rules and laws of total knee replacements. Majority of people go home. About 95 to 98% of people go home. So you have to be prepared when you go home. Most of the time you have a one-night stay. Some people do same-day surgeries, which we do now. But at home you got to be prepared. You need to have someone home with you. And I tell people, the first 7 to 10 days you got to have someone around pretty much 24/7 because there's not a lot of household things you can do. You'll be able to walk around, get to the couch, get to the chair to do your exercises, get to bed, use the bathroom, but you're not going to be able to make food for yourself. You're not going to be able to wash your clothes. You're not going to be able to clean something if something happens. So you need someone around. You need a walker and a cane. Sometimes a raised toilet seat makes things helpful for people because you have to squat low to get on a toilet seat, and that can be difficult after surgery. And then there's other little things that we can do to plan to help out.
You mentioned outpatient knee replacement.
Yeah.
What's the real benefit of that for people?
Yeah, that's a good question. It is a newer thing in the last probably 5 years at our institution. We've really ramped it up in the last 2 to 3 years. The benefit of outpatient knee replacement, it's still kind of, I think the jury's out in my opinion, but the benefit is you do get to go home. You get to sleep in your own bed. You don't have to be in the hospital where you're being awoken by a nurse every few hours for vitals. You're comfortable in your own environment as opposed to being in a hospital room that's usually an all-white room. That's not a very comfortable scene to be in. So that's the benefit of it. And then your rehab starts at home. Home physical therapy goes to your house that day and they work with you. So it's not like you're losing out on some kind of rehab process. The hospital is still important. Most people have some sort of medical condition. It's just the way life is when you get to 50 or 60. And having a hospital setting with a medicine team to be able to keep overnight to make sure you're safe is also important. So there's two different ways we go about that process, and it just depends on which one you're right for.
Yeah, a lot of it has to do with patient expectations and what they want to do too.
Absolutely.
Yeah, I always think it'd be nice to be home, but there's sometimes that it's just not safest.
Yeah.
So, what kind of medicines do patients get after surgery? Things for blood clots, pain?
Good question, yeah. So blood clots is a real risk of any type of surgery you do, whether it's a general surgery or orthopedic surgery. Total joints tends to be higher just because of the location of the surgery and the inflammation that comes about it. The risk is about 2 to 3% for a blood clot, and sometimes around 1% for a PE. So blood clot prevention is important. The medication we use mostly in people who have no risk factors of a blood clot is just a baby aspirin twice a day, which is pretty friendly for people. If you do have a risk for blood clot, you had one previously, you have some type of a genetic blood clot history in the family, if you've had history of cancer or other things that make you what we call pro-thrombotic or pro-clotting. The medications that we sometimes use are Eliquis or Xarelto in a prophylaxis dosing form, or sometimes Lovenox shots. It just depends on a specific practice to do that. With regard to medication for going home with pain, most people will prescribe a narcotic, and oxycodone is usually the most common one. An anti-inflammatory, whether it's something like meloxicam or Celebrex, just depends on the physician's preference. Anti-constipation medications, just to get rid of the side effect of the narcotic, and that's about it.
And a lot of times people are hesitant to take pain medicine, and we all know the risks of narcotic pain medications.
Absolutely.
But I mean, there is a role for them in controlling pain. And I always try to tell people, you're not going to be on this forever.
Correct.
You're probably going to really realistically take it round the clock for the first day or two. And then after that, you start taking less and less of it. And I remember when I was a resident, we'd be prescribing 90, 120 of these pills. And now we send people home with 30, and it lasts them a week.
You're absolutely right. There's also the one thing nerve blocks we give people too, to go home with that last 24 hours to help reduce the pain. But with the narcotics, I give the same line too. My line is, don't be a hero in the first 2 weeks. The one thing you don't want to do is get behind on pain medication and you're at home, you don't have an IV anymore, we can't catch you up. Now you can't do your rehab exercises because you're in pain, and it affects your outcome. So there is a role in narcotics. Obviously narcotics has side effects and they've caused problems in society, but there is a role in them in total joint replacement, which is an incredibly tough rehab to help people get to a place where their outcome is great.
Yeah, and I think one of the things that's really helped with us, like you mentioned, is the nerve block. It doesn't take away all the pain, but it definitely brings people down to a level where we can keep it much better controlled.
Absolutely.
We talked a little bit about assistive devices. What's the usual course of therapy that people have to do afterwards?
Yeah, a home physical therapist we usually see every other day. They'll do light exercises with range of motion, make sure you're walking safely with gait patterns, analyze your home, make sure you're safe. For the first 2 to 3 weeks, you're usually using a walker after a total knee replacement. It's mostly for safety concerns to make sure you don't fall, because the last thing you'd want is have a fall, a fracture that can affect your outcome, something like that. After you're done with the walker, it's usually another 2 weeks with the cane. Again, same thing, you're just making sure you're safe walking and not going to be a fall risk. And by 4, 5, 6 weeks, you're walking on your own. Usually around the 3-4 week mark, most people are going to an outpatient physical therapist, and that's where physical therapy kind of jumps and gets a little bit more intense. And what I mean by that is you're doing a lot more stretching exercises to get your motion, because your wound's finally kind of healed, your inside joint capsule's kind of healed, so your knee can take a lot more stretching. And the goal is to get your motion back, because that's what's most important. There's a little bit of light muscle strengthening, but my emphasis, and I think most people's are, in the first 6 weeks is range of motion, because You only really have 12 weeks to get your range of motion for your knee. After that, usually whatever you have is permanent. So there's different cutoffs I have at different weeks to make sure people are there. There's different things that I'll edit if they're not there to get them, and it's all pretty guided by the physical therapist. Then, usually when you're at the 12-week mark, your motion's final, they're doing strengthening stuff to get you back up to speed. Usually around 10 to 12 weeks is when life activity things start to happen again. I'm not saying you're going out and golfing 18 holes, you're not jogging miles or anything like that, but you're actually starting to do some things like that. I tell people if you're a golfer, you're probably able to start going to the golf range and take a half swing and maybe a full swing if it feels okay. You're able to start walking in the park, start with a half mile and build up slowly, because what I tell people is you won't feel it when it happens, but the next day is when you're going to feel it. It can set you back. And traveling at 10 to 12 weeks is when I let people do that as well. And then over the course of 3 months to 6 months to a year, your knee is still rehabbing. There's still low-grade inflammation in your knee. It's a traumatic event. It's a surgery. Your body's recovering. And it takes a long time to get back to what you really want to do. Play 18 holes of golf, walk 4 or 5 miles a day, travel on an airplane, go swimming and stuff like that. Those things can take an extended period of time to get back to what you were before.
Yeah. And one of those things in the questions I always hear is, I heard I can't kneel on it.
Yeah, that's always a classic question. And I'm sure your message is the same. Mine is, you can kneel on it. It won't damage the components. It may not feel good to you though. I always encourage you can put knee pads on, you can put foam down. And I just let them know it's going to feel uncomfortable. It's not going to break. It's not going to fracture. It's not going to come apart. You just won't like it. So you can still do those activities, but it just might not be enjoyable. And it's just the nature of knee replacements.
I think it's verbatim what I tell people.
100%, yeah. It's always I can't kneel in church or something like that. And I don't, I'm obviously a little bit of a younger surgeon, but I wasn't back in the day where that was like, you can't kneel at all. That used to be the message, and that's not true. So.
Yeah, it's a little bit of historical to the significance to that. And it is funny because people will say it, or they'll say, I tried to kneel on it, and I say, how'd it feel? And it's almost always, it feels weird.
Yeah.
It doesn't.
It is like
I don't like it.
This thing that clicks a little bit when it does. So.
What other activities do you tell people they can or can't get back to?
So it's tough. There's never been studies on knee replacements for someone who's like, I want to go and squat 300 pounds, or I want to go run a marathon on it. We don't have the studies. We don't know. But and kind of like what you alluded to before, I tell them it's tires on a car. So you got a car and there's tires on it. You can either drag race the car and your tires are going to wear out incredibly fast, or you can keep the car in the garage and never drive it. What's the point of getting new tires on your car? There's some place in the middle that you have to live with that. So I tell someone if they're a jogger or they're like a marathon runner, you're probably not going to run marathons on it. Can you do it? Sure, it's probably not going to feel great, but you're probably going to wear out the component. You got to adjust your life, whether it's using the elliptical, jogging slower at a shorter distance, doing more machine things with lifting or swimming or something. There's some amount of adjustment that needs to happen with it. So yeah, there are certain activities that are tough on knee replacements. A long distance run at a high intensity, any kind of free weight lifting's tough on a knee. Side to side movement's tough on a knee. Playing tennis, pickleball, most people can do things like that, but cutting side to side on tennis, playing basketball side to side, that's something that a knee replacement is not designed to do. It's a tough thing for someone to get back to something like that.
I think people can do it. They just may not do it at the level that
Correct.
they once had. Skiing is another one. We get a lot of questions. Yep. I mean, not as many now. We live in Ohio, but I previously lived in New England, and people would ask, "Can I go back to skiing?" And people can ski on them.
Correct.
It's the same type of thing. If you peel out of every stop sign you go to in your car, you're going to wear out those tires pretty fast. So you have to make a decision what's important to you as a patient, what you want to do in your life, what you're getting this knee for, and when do you want to have it redone.
100%. And usually our goal is try to do the one surgery that's going to last your whole life. And a knee revision surgery, which is a surgery a second time, isn't as simple as going in there, pulling a piece of plastic out and put a new one in. A lot of times it's more invasive. It's a bigger surgery. It's a longer recovery. It has higher risks that are usually double in all the risk categories. And those knees don't even last as long with that. So there is some education we have to provide to let people know, like, listen, you really want this knee to last the rest of your life, because being a revision patient is a totally different outcome and story.
Totally, and we want people, and a lot of times we'll say, well, you're on the younger side, and
Correct.
From an age perspective, the patients that we operate on, I think of 55 that's on the younger side for a knee replacement. So anything under than that, younger than that is certainly young for a knee replacement. Although we do it, I would say we do it in a sense somewhat reluctantly because we want these things to last a long time. There's not really a top end for me personally. As long as people are active enough, functional, and their knee is limiting them, we can replace it. But they have to be healthy enough for surgery.
True. And to your comment of the young patients that we get sometimes, some people have conditions, whether it's a deformity, avascular necrosis. There's multiple things that can sometimes lead to someone to have early knee arthritis. And we get kind of, back in the day, our answer was we can't do anything. And that was back when the plastic or the polyethylene we used didn't last long. It had to do with how they fabricated it, how they machined it. It only lasted 10 to 15 years. Now we're lucky we live in a time where the way they manufacture it lasts 20, 25 years, or studies still on how long they can, where those people are now able to receive a total knee replacement. But like you said, if someone comes in and they're 40 or 50, 20, 25 years, you're still living, you're 75, and you probably still have a little bit of active lifestyle left in you, that a knee revision surgery is still a possibility.
So when people get home, what are the potential complications that they can have, and what are the kind of red flags that they should be looking out for?
Yeah, good question. So the one that obviously scares us as surgeons and patients the most is infection. We live in a world where there's bacteria on your skin. Bacteria, when people think of bacteria, when I get a knee infection, is it from the instrumentation? Is it from something that was on the thing that went in? No, we live in a world where you're covered with bacteria on your skin. We clean you, we prep you, we make it as sterile as possible, but that can lead to infection. The risk for infection in total knees is around 1%. That's probably the most complication we fear the most and the most common one. The red flags for something like that, usually you won't have a sign in the first 5-6 days. Usually it's after that. You'll have increased pain. You can spike a fever that happens, it plateaus. Cyclic can go up and down. That's common after a knee. That happens in everybody. But if you have a fever that stays high the whole time, your knee gets red, you get drainage or the wound's not healing corrected, those are red flag signs that an infection could be happening. The other one we talked about earlier was blood clots. It's about a 3% risk of a blood clot after a knee replacement surgery. The red flags for that, it's a little bit more tougher to diagnose. It's usually calf pain, swelling, that's getting worse and worse. Someone that you suspect who's a high risk, things like that. And what we do is we send people for an ultrasound to see if there's any kind of blood clot in the back, which can increase the type of medication we're using to thin your blood. Other complications that can be associated with knee replacements, stiffness. That's where rehab is important. And our job obviously is to put the components in the best position to allow your knee to get the range of motion and function, but also rehab is important. You got to get to a functional range of motion. Our ideal range of motion is something greater than 120 degrees. Does everyone have to get there? We like to, not everyone does. Functionally, everyone has to get past 110. If you get less than 110, there's a lot of limitations in life that can affect you. And if you get stiff, obviously through the 12 weeks we're trying to edit things to get you there. If it's not working, there are certain things we can do up to that point to do that, but that is a common complication of knee replacements. Other ones, fracture during the case, that's pretty rare, but we fix it if that were to happen. Arterial injuries, nerve injuries, very rare, especially with robotics. It makes it a lot safer even with that, but that's probably the most common ones.
What are probably the most common complaints you hear from people after they've had their knee replacement?
Yeah. One is stiffness. Again, it's a 6-month process. At 12 weeks, you usually have your final motion, but you still feel this swelling in your knee, this stiff feeling in your knee, even though your motion may have come back. So a lot of people are like, I still feel kind of tight up front. After I do the activities I truly enjoy, I get swollen still. I feel like I have to stretch it out in the morning a lot. It takes me a while to get going. That's usually one of the more common things I feel. And usually it's someone who's about 2-3 months out starting to get back to it. And when I tell them and I warn them, well, listen, you're feeling good now. You're going to get active. You're using muscles you haven't used in a long time. Your knee underwent a traumatic event where we sawed your bone, and that causes a bunch of inflammation. So when you do something, you're going to stir that inflammation up again, and that can last 3, 5, 6 months to happen. Other common things I'll hear after a knee is my knee clicks a little bit. That is common, and it's not a bad thing. If it clicks and hurts, that's a bad thing. If it's just a click that you hear sometimes when you bend your knee or when you first get going, it's just the components touching each other, and that's all it is. And it could be your knee's just a little bit swollen from the early post-op period, and it's just off by a few millimeters and it comes together. It eventually corrects itself over time. And other times it's, I'm not getting back to the activity I really want to do. And our job before the surgery is to set the expectation. And we talked about if someone's a basketball player and like, hey, I can't play full court basketball anymore. That was our job to tell you, like, listen, yeah, can you play half court, shoot around, do those things? Maybe, but we need to let that person know, like, listen, playing full court, cutting in and out, weaving in the lanes is probably not going to happen. Sometimes the expectation not being set or the person expecting to be able to do that can be a common complaint after surgery.
Here's a common one I hear.
Yeah.
It's numb right here.
Yeah, that's the good one. That's probably the most common one. Everyone has numbness after a total knee replacement. And it has to do with how your nerves supply your skin. They cross over your knee and we make an incision. They're microscopic. We can't see them. We can't dissect them out and go around them. They get sacrificed in the incision, in all incisions with total knee replacements, and everyone across the country, and what everybody does. So you get numbness over the inside of your knee. It lasts about a year. What happens is your brain adapts. It's not that the nerves regenerate or regrow, but your brain adapts to a point where that numbness doesn't feel anymore and it goes away.
And we talked a little bit about redoing knee replacements. What happens when a knee replacement fails?
Yeah, so there's a lot of ways knee replacements can fail. Infection's one that we talked about. Your a polywear, your plastic wearing out from years of it being worn or something. Sometimes they catastrophically can fail, which is rare, but it happens. A loosening of the components. Historically we cemented most knees in place, which is a kind of a cement grout that would stick the implants on your bone. Now we have press fit ones that your bone grow into, and the thought is because they grow into them, it lasts longer because that grout's no longer there, but they can loosen up and wiggle loose and cause bone loss or instability, whether it was put in and it became unstable or it was unstable at the time of surgery or you had an injury after the knee replacement that made it unstable. That can be a cause for a revision. The type of knee revision surgery depends on the problem that ultimately led to it. Majority of the time, knee replacement surgery unfortunately requires removal of most of the components. It's rare that we can just swap a piece of plastic out, put it in, get it balanced again, and you can just go back to everything. Usually there's something that has ultimately failed that we have to address and remove one or two of the components and put it back in. The problem with knee revision surgery is we have to remove them safely. We got to chip them out from your bone because they're still attached at some places, or sometimes the one component's loose and the other one's not. And you lose bone in that situation, and we have to rebuild it back to a correct level so your biomechanics of how your knee works is the same. And all that is a lengthy surgery. A knee replacement that is your first time is an hour and a half. Knee revision surgery can be 2.5, 3, 4 hours, depending on how complex it is. So.
What's your best one piece of advice when people tell you meet somebody on the street, they know who you are, and they say, my knee is killing me, I think I need to have it replaced? What do you tell? What's your advice?
I ask, how bad does it hurt? Can you do the things you still enjoy and still tolerate it to a point? Like if you take a medication, can you go back to the activity and do it? Is it dominating your life in a way that you lose sleep? You are behind in your family in terms of you go on vacation, you got to sit and not do anything and not be with them. I ask, has it changed the things you enjoy? Like, can you no longer golf? Can you no longer walk? What things have you tried? And have you tried everything in terms of medications, injections, things like that? And then if they answer yes to many questions, it's keeping me up. I can't do the things I enjoy. I'm behind with my family. I can't keep up with them when they do stuff. Then I tell them that a knee replacement could be right for you. The big thing that I think is the theme of the day is we set the expectation of what a knee replacement is. It's not a surgery that's going to get you back to it right away. It's going to take 6 months of your life to a year to get back to where you are. And it's a serious commitment on your part and our part to get you there.
Yeah, it's exactly. And a lot of times I hear from people that haven't had a whole lot of conservative treatment, things like anti-inflammatories or injections. They say, I don't want a shot, it's just a Band-Aid. And a lot of times my response to that is sometimes all you need is a Band-Aid.
Yep.
If a Band-Aid works, it's better than a trip to the ER.
100%.
Better than stitches.
Yeah.
So if you haven't had an injection and you try one and it gives you 6, 9, 12 months of relief and it works great, there's nothing wrong with that.
Absolutely. It's a low-risk procedure that gets you back to your life, and you got 9 months of your life back with having a major procedure. And you can sometimes get another one that sometimes can last just as long or maybe a little bit shorter. They can keep you away from it. So they're important, and it's jumping to knee replacement is not always the right thing. What I will say for some people is if you've had a hip replacement and you're going to get a knee replacement, they are not the same recovery and not the same surgery. Hip replacements, they fly. They get their surgery done, they have some pain, but they rehab quick. Knees are not the same. Knees are tough. It's a lot more dedication, physical therapy, and a lot more soreness than hips do.
I definitely agree.
Yeah.
And that fits right in with what my line to people is keep your own parts as long as you can. When you can't deal with them anymore, then knee replacement may be an option for you, but yeah, it's nothing quite like what you started life with.
100%.
Where do you see the future of knee replacements going?
I think, we've made a lot of leaps and bounds over the last 5 to 10 years. We talked about the plastic being manufactured in a way, in the last 15 years that they last 20, 25 years. We have cementless technology where before, we had it before, but it failed. It didn't take in, 10 to 15% of people. But before we were cementing knees in, there was a cement grout that kept your knee attached to your bone. But unfortunately, that grout sometimes loosened up and they only lasted, 20, 25 years. And now we have components that your bone grows into and actually works. And, recent studies have showed that 98 to 99% of them take and they grow in. And now that there's no material that's between your bone and it's grown into the implants, the thought is now it can last longer and not loosen up. With regard to how we're putting them in, robotic technology has revolutionized our field in the last 5 years, like 5 to 10 years now. It's been here for a while. It's only grown. The software, the application, the accuracy, how we balance it, the ability to do revisions with the robotic platforms. There's handheld robotics. There's ones that move on their own that are coming out. I think it's just going to keep getting more innovative in how we do knee replacement. The principles will always be the same, but the reproducibility, the safety, and the ability of robotics to keep developing, it's going to make it just probably more safer, quicker, and reproducible.
Yeah, I agree. Eventually I think we'll see some more improvements on implants, but the implants now they're not bad.
No.
So they're not quite what you started life with, but they're better than they used to be.
Yep,
so.
And there's something that can last a lot longer now.
Well, I think on that note, it's time to wrap up things. I'd like to thank our guest, Dr. Nicholas Scarcella from the Cleveland Clinic. And I hope the listeners were really able to gain a lot of information about knee replacements, what they are, what they aren't, what the recovery is like. And we thank you very much for the time that you gave us.
Appreciate being here. Thanks.
This has been the Ortho Info Podcast, brought to you by the American Academy of Orthopedic Surgeons. Production and editing by MK Quinn Media. You can find the Ortho Info Podcast on orthoinfo.org and wherever you get your podcasts. Like and subscribe so you won't miss new episodes, and visit the Ortho Info YouTube channel for full video podcast episodes and shorts. The views and opinions expressed by guests are their own, and their appearance on the podcast does not imply an endorsement of them or any entity they represent by the AAOS. Reference to any specific product, device, or service during this podcast is for educational purposes only and does not constitute endorsement or recommendation by the AAOS. Ortho Info. Expert musculoskeletal health information provided by surgeons, trusted by patients.